Everyone's time. I think we should just get started. My name is Jerry Kagodo, and I am an associate professor at the College of Social Work at The Ohio State University. And on behalf of all our co-sponsors for this event, the Arnhold Institute for Global Health at the Icahn School of Medicine at Mount Sinai, the Elmhurst Global Health Institute, Nepal Rising, and Justice is Global, I want to welcome you to this second part in our three-part global event on vaccine apartheid. Now, I want to remind you that this is a meeting format. It is not a webinar. So your cameras and your microphones are live, so you might want to mute yourself. Now, at the College of Social Work at The Ohio State University, one of our missions is to prepare leaders who are committed to social justice. Social work leaders who recognize both indigenous and global power systems that are hell-bent on maintaining the current status quo. At the College of Social Work, we also prepare social work leaders who, on realizing what they're up against, are resilient enough to keep drawing on their skills and their savvy to navigate the systems, and when it is demanded of them, have the courage to challenge and dismantle these oppressive power structures. And that is what brings us here today. The current situation we find ourselves in, vaccine apartheid. A system of segregation driven by vaccine nationalism, where wealthy governments have captured vaccine supplies at the expense of those of us living in developing economies. What we know is that vaccine inequality at today's scale could cost the world as much as $9.2 trillion US, with rich countries bearing at least half of these costs. It is estimated that we need about 10 billion vaccines globally, and while the G7 has committed 1 billion vaccines staggered over 2 years, it is clear to anyone who is paying attention that that strategy that depends entirely on vaccine donations is insufficient. To stop this disease, we need a multi-pronged approach, one which will include, yes, vaccine transfers, but also the transfer of technology and technology sharing to allow our countries to manufacture and disseminate our own vaccine. Now, we only have an hour together today. So before I hand over to Dr. Rachel Berman, I want to remind you again that there is closed captioning. Closed captioning is available. This is a Zoom meeting, not a webinar. So please feel free to drop in on the chat and share your thoughts and resources and any upcoming social actions you want us to participate in, and to also complete an evaluation at the end of this session. Now, Dr. Rachel Berman is the chair of the Department of Health System Design and Global Health at the Icahn School of Medicine at Mount Sinai. She's also the director of the Arnhold Institute of Global Health. Dr. Berman is a professor of pediatrics with an extensive history of leadership, building global health research programs that generate evidence needed to improve care systems around the world. Her own research, which focuses on improving the care of children and adolescents living in HIV resource-limited settings. She's an international expert on adolescents and health in sub-Saharan Africa. She's also the immediate past director of research for the Empath Research Network in Kenya, a network which provides HIV treatment for over 150,000 patients in the country, and is also building a comprehensive healthcare model in partnership with our Ministry of Health. Dr. Berman now leads the Mount Sinai's participation in the Empath Consortium. Now, well, that short bio does not begin to do you justice. Rachel, I will now hand it over to you and you can introduce our panelists and take it away.
That's plenty. Thank you so much, Dr. Kagotho. It's really an honor to be able to facilitate this discussion today, and that's really my role. As Dr. Kagotho has framed for us, this is such a critical issue right now for everyone who cares about social justice, about global health, about what it looks like to truly end this pandemic for all of us. And I'm really delighted to be able to take part in turning a lens towards Kenya for today's discussion of global vaccine apartheid. I have had the privilege as a pediatrician and an HIV researcher, as she described, to partner around work in Kenya since about 2004. And out of that partnership, my own passion and love for what it looks like to build up equitable health systems in Kenya and elsewhere in East Africa is very strong. So I'm really delighted to be able to highlight our experts joining us today. And again, on behalf of the Arnhold Institute for Global Health and our co-sponsors at the Ohio State University School of Social Work, Justice is Global, the Elmhurst Global Health Institute, and Nepal Rising, we're just really thankful that people joined us today. Again, please be thinking of questions. We want this to be an interactive time. Think of questions to put in the chat. You're welcome to introduce yourself in the chat. And we are going to have a specific action moment as well as time goes on. So let me introduce our panelists for the discussion today. I'm incredibly privileged to be joined by Dr. Pauline Mushina and Dr. Lukoya Atwali. Dr. Pauline Mushina comes from the Rift Valley province in Kenya, where her family still resides. She is the founder of the Future African Leaders Project, and she is a fellow with the Center for Health and Social Policy. She's the representative for Africa in the American Friends Service Committee, where she's the policy, education, and advocacy coordinator. And she's responsible for education and advocacy work, strategic initiatives and coalition building, and resource development, both in the United States and globally. She's previously served as a senior partnership advisor for UNAIDS, and she serves on multiple boards and advisory groups, including the Foundation for Sustainable Development and the Circle of Concerned African Women Theologians. She also supports organizations like African Women and Youth, which is a handmade creative design company that crafts authentic handmade African products for the global market. She has multiple awards in her history, including in 2011, she received the United Methodist Church's Global Leadership Award. And in 2014, the Huffington Post honored her as one of 50 women who are powerful international religious leaders. She has a master's degree from Yale University's School of Divinity and a PhD from the Union Theological Seminary. And Dr. Mushina, we are so honored to welcome you today. I'll note that Dr. Mushina's voice is a little bit tired today because she has been out protesting for vaccine equity in other circles as well, but we are so grateful to have her voice with us today. We also have Dr. Lukoya Atwali joining us. Dr. Atwali is the Dean of the Icahn Medical College of East Africa. He is a professor of psychiatry and he has extensive leadership, teaching, and academic research expertise as well. Professor Atwali, Dr. Atwali leads and participates in mental health research, both locally in Kenya and globally. He's a member of the World Health Organization's World Mental Health Surveys Consortium, which is a leading collaborative project in psychiatric care and epidemiology globally. He also has served as the global technical director for the Cities Rise initiative, whose goal is to make 5 cities mental health friendly with a specific focus on young people in those cities. Professor Atwali was formerly the Dean of the Moi University School of Medicine, where he has a long history of building global collaborations and partnerships between the School of Medicine and academic medical centers across Africa, Europe, and the United States, and transforming that medical school into a leader in research and graduate medical education. He also is a significant influencer of health policy in Kenya, particularly related to mental health policy and equity, and speaks on this topic more broadly on the continent. To this end, he has served as the Vice President of the Kenyan Medical Association, and he holds positions with the African Association of Psychiatrists, the African College of Neuropsychopharmacology, and the World Psychiatric Association. Dr. Lukoya Atwali has a bachelor's degree of medicine and a bachelor of surgery from Moi University. He completed a residency and master of medicine in psychiatry at the University of Nairobi. And he also has a PhD from the Department of Psychiatry and Mental Health at the University of Cape Town in South Africa. He is a visiting scientist at the Harvard T.H. Chan School of Public Health and an honorary associate professor of the Department of Psychiatry and Mental Health at the University of Cape Town. We really are honored to have Dr. Atwali joining us as well today, and I'm looking forward to this discussion with both of you so much. So as Dr. Kagotho really framed for us so well, We come together today at a moment where the global apartheid in vaccine access has become increasingly apparent. There is a huge divide between the United States and Europe and other high-income countries and many of the low and middle-income countries. At our current pace, where we still have 10 billion vaccines needed to approach vaccine coverage for COVID-19, only 9 out of the 10 people living in the world's poorest countries right now will not be getting an effective COVID-19 vaccine within the next year. If we look at the continent of Africa, we see that only 40 million doses have been received across the continent for a population of 1.2 billion people. So we come together in the face of this pandemic that continues to impact all of us, but seeing this incredible inequity that we want to talk about and figure out how we best might address today. Now, as we've been talking about in this series, for those of you who joined us previously, we had a focus on Nepal to frame our work and our consideration in the last discussion. And today we're going to be focusing on Kenya. Dr. Atwali, I hoped you could begin for us with describing a bit about the current situation of the COVID-19 pandemic in Kenya in terms of outbreaks currently being faced and vaccine access in particular.
Thank you very much, Rachel, and it's a pleasure to be here and to join this very important conversation on vaccine apartheid. For a long time, I have campaigned against broadly health apartheid, which in many global health arenas has it that if you're a poor country, then you're a candidate for second-class medicine and second-class care, or no care at all. And if you have more resources, then you get the standard of care that is evidence-based. And this COVID-19 has exposed this divide starkly and perhaps pushed us to have to start thinking about getting rid of health apartheid from our global health conversations. So COVID-19 arrived in Kenya in March 2020, March last year. And we had the first peak. The numbers rose gradually, and the first peak was somewhere around July last year. And since then, every 3 to 4 months, we have another peak, and every peak is higher than the previous one. And when I talk about peaks, I'm talking about the numbers of new cases every day, as well as the numbers of fatalities. So every 3 to 4 months, they peak. So we had another peak in October, November last year. And this year, February, March, we had yet another peak. And right now, we are at the beginning of a fourth peak since COVID-19 arrived here. The COVID-19 pandemic in Kenya has been characterized by many things, a lot of them negative things, but the 3 main things that I would highlight today is firstly, under-testing. So since last year, March, only about 2 million tests have been carried out in this country on COVID-19. And this is in a population of 50 million. And if you take into consideration that some people have been tested multiple times, so you can imagine the proportion of the population that even has had access to a COVID-19 test. We do know that a significant proportion of our population has been exposed to COVID-19, certainly more than 2 million people. And therefore, any numbers that we report from the tests that we have done will definitely be an underestimate of the true scale of the pandemic in our country. The second thing that has characterized this pandemic has been limited capacity to take care of people with moderate to severe symptoms with COVID-19 in this country. And indeed, every peak that has occurred has extremely stretched the health system. And many, many people have died preventable deaths because they couldn't access a facility that has oxygen or simple supportive care that would have saved their lives. So this is the second thing that has characterized this pandemic in this part of the world. And the third thing that is relatively more recent is the limited access to vaccines. So, we started discussing vaccines towards the end of last year, and it was hoped that everybody who is at risk would have access to these vaccines and that everybody would think the same way. But unfortunately, this has not been the case. Kenya signed up onto the COVAX mechanism and received just about 1 million doses of the vaccines at first. And so close to 1 million people have received 1 dose of the vaccine. And as of yesterday, another just over 200,000 100,000 had received a second dose. So only about 0.8% of the population is fully vaccinated as we speak. As far as the numbers are concerned, and the reason why we are worried about a fourth peak, yesterday we had 741 new cases of COVID-19, representing a positivity rate of more than 10%. And this had gone down significantly to less than 5% in recent weeks. So this is the situation at the moment. And we are still looking, we received another consignment of vaccines, about 300,000 to facilitate the second dose of AstraZeneca, but this is way too little. And we are afraid that a significant proportion of our people who could have been protected will not have access to this protection, even with these vaccines that we're getting at the moment. Thanks, Rachel.
Thank you so much, Dr. Twali. That's a really terrific overview of the current status in Kenya. Dr. Mushina, we'll turn to you. And again, thank you so much for joining us today. I would love to have you start with your thoughts about what must be done to expand access to these vaccines.
Thank you very much. It's an honor to be with Dr. Twali. I've only read about you and the many great works that you do for our country. And I just want to say thank you. And also to the organizers of this important conference. I apologize that my voice is not as good because I have a cold and we were shouting as much as we can yesterday at the European Union Consulate in Washington, DC, calling Angela Merkel and Boris Johnson to stop vaccine apartheid. Because even as the US and other rich countries start to return to the new normal, because we've had access to vaccines, like I got a cold, but I'm not worried because I know I'm fully vaccinated. Even as we return to the new normal, you know, we are also very worried for our brothers and sisters around the globe because they don't have access. Kenya as well, where I come from. My mother is in her 90s and she has not been vaccinated yet. And that just put things into perspective. And also the many medical doctors and medical professions that we are losing at a very high rate is very concerning, and that we really need to get those vaccines to people's arms as quickly as possible. And yet, the countries that have succeeded to get vaccines have so far refused to share the technology to share the vaccines or to produce the vaccines. We know that even within the United States itself, it was very hard for the three companies, Johnson, Moderna, and also, Johnson & Johnson, Moderna, and Pfizer, to produce enough vaccines to vaccinate everybody in the United States. So to ask those three companies and a few others in Europe and China and Russia to produce vaccines to meet the world demand, which is 7 billion doses, is impossible. And they know that because so far, not even 1 billion people in the world have been vaccinated. And the doses that the G7 countries that offered, which was 1 billion, cannot even vaccinate India, which is going through a very huge crisis right now. And even the doses that the US government has offered, 500,000 to low and middle income countries, is not going to meet the demand. We will not be able to vaccinate people in low and middle income, and especially in places like my home country, Kenya, until 2024. What does that mean? Because as Dr. Twali has just told us, people are getting infected, people are dying, and to say that they are not going to have access to vaccines until 2024, what will happen between now and 2024? Are we going to see another killer disease like the AIDS pandemic and the way it killed 30 million Africans before ARVs arrived in the continent? And our ARVs were being accessible for others in the United States and other parts of the world. So what do we need to do to make sure that vaccines get to Africa? The most important thing right now is for the World Trade Organization to approve TRIPS, the temporary TRIPS waiver, or IP, intellectual property licensing, so that companies in African countries are able to produce vaccines locally instead of waiting for these few companies to produce vaccines and then ship them at a very high cost to developing countries. What is preventing them from sharing that technology to save lives? There is a policy within United Nations and also within the World Trade Organizations that in a time of emergency, intellectual property waiver takes place so that whatever ingredient or tool that is supposed to save lives can actually save lives. Just yesterday, the European Union issued a statement and a new proposal suggesting that they need to revisit that policy because they are now arguing that there are some loopholes. Somehow there are some loopholes in that policy when it comes to releasing the intellectual property so that we can manufacture local vaccines that can save lives immediately instead of waiting until 2024. South Africa and India has already made a proposal, and some of the European nations led by Germany and the United Kingdom are the ones that are opposing that proposal and bringing unnecessary blocks, unnecessary debate while people are dying, while people are getting infected, while the economic downturn is devastating poor and middle-income countries. We are asking them, for how long are they going to watch people die while they are debating about policy? But it's really not policy that's an issue here. The issue here is profit. And these pharmaceutical companies are making a huge amount of money using taxpayers' dollars. You and I pay taxes in the United States. All three companies use taxpayer money to manufacture those vaccines. And now they want to make the profit alone instead of sharing the technology to save lives. They forget that if Kenya is not safe, if India is not safe, if Uganda is not safe, the new variants, like the Delta one that is now devastating countries around the world and has actually also arrived here, will undermine the achievements of the vaccines that they've already done here in the United States. So there is need to do it and do it quickly. So we are urging the members of European Union, we are urging countries like Canada, Brazil, that are still standing on the fence to get out of their high horses and allow the temporary TRIPS waiver so that mass production of vaccines can happen around the globe and African countries can actually produce vaccines and save lives. And I want to end this by saying that I also hold African countries accountable for what's happening to African people, because we knew we were dependent on imports of essential health services. And instead of prioritizing things like vaccines, ventilators, or life-saving tools, diagnostic tools, we depended on China to provide that to us. We depended on other countries like Western countries to provide that for us. Who does that? You don't rely on someone else to save your life. African countries have to get up. This is the time. They need to realize, actually, COVID is just a wake-up call, that if we don't really invest in health systems in Africa, we are going to fail miserably. This is just a start. With the environmental crisis that we are seeing, COVID is just a start. And if African countries do not begin providing their people with health tools within the continent, medication within the continent, diagnostic tools within the continent, vaccines within the continent, we are going to continue to see suffering, actually untold suffering. So it is upon ourselves, but it is also upon those who already have. As a person of faith, I believe in sharing of what God has provided. So the countries that already have must have a responsibility of sharing what they have. Thank you.
Thank you so much, Dr. Machina. There's so much there that was good and powerful and important that we could talk about. I think you really brought forward so many critical points in terms of what is necessary, who needs to accept responsibility, where there are changes that can be made in this way. And, I think it is a really critical point that we often miss when we think about this, especially in a country like the United States, where we have, where we have had access to so many of the medicines and vaccines that, just as you said, it is not just a question of COVAX and having enough doses donated, although certainly we appreciate that and that is a part of it, but this critical process in terms of what it really will look like to produce the billions of vaccines that are needed and to broaden that access, that the waivers in order for the permission to make the vaccines need to be in place, that we need to have these transfers of technology and of the full range of technologies that are needed for vaccines to be produced. And of course, as a final stage with that, having the adequate materials and what components are needed for actually making the vaccines in that. But there are these, this is not something that we're just dreaming about, that's not within their power, that is not, that is some sort of abstract brand new policy. Just as you said, these technologies were developed with the resources of countries like the United States, and they absolutely could, require that those technologies and the intellectual property in which they've invested and that they supported for this be shared appropriately across the range of technology that would be needed in this way. You said it much more eloquently than me too, so I won't try to summarize all that you have shared.
Let's. One point I would like to make is that the US government has already approved the sharing of technology. They have approved the TRIPS waiver, so they are on the right side of history, but they need to be forceful with the countries that have not. Thank you.
Absolutely. Thank you. I think that's a great point too, in terms of the role of advocacy across these countries as well. Dr. Atwali, returning to you. So as we think about these ideas of technology transfers and manufacturing, and returning to the focus on Kenya as well. As we looked at this together, it does seem like the University of Nairobi, for example, and other potential manufacturers in Kenya might have the ability to undertake vaccine production. But of course, this would require some sort of critical support for technology transfer to be able to move to that full capacity to produce vaccines and then make them accessible to the public in Kenya and beyond. Do you have, what are your thoughts about how countries like the United States or other allies of Kenya might support manufacturing capacity in Kenya or support this process of increasing vaccine access more broadly?
Thank you very much, Rachel. And I want to firstly begin by echoing what Pauline has very powerfully put across, that there are ways in which this can be resolved if people just stopped thinking about profits and started thinking about lives. So I think that to me is an important segue into this discussion. And one of the things that I do, I teach at medical schools. I've taught for several years. One of the things I teach my students is sometimes there will be laws and policies that come in the way between you and your patient. And I teach them that it is your ethical responsibility to break those laws and then deal with the consequences later, save the lives, and then answer the questions later. And I get extremely frustrated when governments that are vowed to take responsibility for the health of the population cannot see it that way, that whatever these international protocols have been put in place to protect profits can actually be broken in order to save lives. And then we can spend time in courts discussing why this was broken, why this happened, but we will be doing this with millions of people alive and healthy. So, and the second thing is that vaccine production and vaccine philosophy theories and the science of vaccines is very old. It's not necessarily as new as people might think, because I mean, it started a long time ago with somebody inoculating people with a harmless virus and then preventing a more serious illness, in the eras of chickenpox and so on and so forth. So it's not rocket science, so to speak. And in Kenya, for many, many years, we have been producing veterinary vaccines. There is a Kenya Veterinary Vaccines Production Institute here in Nairobi that has been supplying farmers and livestock owners with vaccines to prevent common livestock diseases. The technology is there, the know-how is there. At the University of Nairobi and in many of our universities, people teach immunology, people have the capacity to do this. And at the moment, many of our research institutions, including the Kenya Medical Research Institute, are participating in vaccine research, human vaccine trials. So we do have people who know what this is all about. The biggest handicap to begin with, the first handicap, is the intellectual property stuff that since we have made this thing, then we can't tell you how it is made. And even if you know how it is made, you can't make it because we own the patent. And that kind of nonsense that stands in the way of people being protected from this pandemic. And the second thing, of course, then, is lack of investment in the research capacity and in the production capacity. So our governments and other funding agencies haven't spent sufficient amounts of resources to ensure that these institutes like the Kenya Vaccines Production Institute or similar institutes ramp up the capacity and are able to pivot to provide vaccines that will protect us from this scourge. Recently, 1 month ago, the Kenya government launched a new initiative for human vaccines production, bringing together the Kenya Medical Research Institute and several universities in the country and other research institutions. It's still at a conceptual stage at the moment, and therefore requires a lot of support. And some of the support has been alluded to already. And this includes partnering with institutions like in the US and in other countries that are already producing these vaccines to ramp up the capacity very quickly, put in place whatever technology is required to produce these specific vaccines and allow us to start doing so as soon as possible. And I believe that with waiver of this intellectual property business and then putting some money into these initiatives would see us being capable to start producing sufficient vaccines to cover our region in East Africa. So I think it is possible, and we just need to stop thinking about profits and start thinking about lives. I think American scientists and health workers have a role, and scientists and health workers across the world in countries that are producing huge amounts of the vaccine and hoarding them, they have a responsibility as well. And the responsibility is exemplified by what we have done in the academic community with the open access movement, where many of us have refused to publish our work in journals that will make profits by restricting access to people who actually need the findings of our research. The same way, if I was a scientist involved in vaccine research, I would firstly publish my work in open access journals. And secondly, I would insist that any commercial product that comes out of it is also open access so that the people who need it most can have access to it. So those of us in science, those of us in health have a responsibility to start thinking creatively about our intellectual property and how it is used by industry and other countries for profit and also for diplomacy. So if we refuse to get involved in such schemes, we can start driving the agenda towards a more holistic, a more global health view. I think African governments, again, and like my own government, has a responsibility to support us, to support those of us who are involved in this research, those of us who are involved in advocacy for vaccine production, by demonstrably putting aside money when they're budgeting that would go to support these institutions, instead of us depending on institutions that come from elsewhere. Every entity that is funding anything has an agenda, and that agenda doesn't always coincide with the agenda of those that are receiving whatever is being studied. Above all, I think COVID-19 has taught us that there are no safe havens. There's nowhere that is safe. As long as a corner of the globe is under threat, all of us are under threat. And our thinking has to change. The scientists must lead that shift in thinking. We can't sit back and let politicians lead the conversation, because the politicians often have short-sighted views depending on the election cycles wherever they are. So I think that is my contribution at this point. But I think if we think about lives before we think about profits and commercial interests, it will be a no-brainer as to what needs to be done now to save lives. Thanks.
Thank you. I agree with you so much. And you continue to teach me as well. You know, after quite a number of years of working in the midst of HIV, you know, this has continued to be at times a surprising learning process for me. There were so many years taking care of patients living with HIV and trying to do work around how to best support families with children with HIV, where I was so burdened by constantly, daily, by the gravity of losing 1 million people to HIV every year. And I often thought, as I would return to the United States, in the midst of this, that, you know, surely if this HIV pandemic was impacting people here in this country in the same way, it's immediately they would take more action, they would understand, we would have, you know, better medicines, we would, you know, be further along with this. And sadly, this pandemic, I'm afraid, has taught me even more the ways in which inequity, racism, bias, the holding on of power and profits, and how health becomes politicized in the midst of this has made that untrue, that despite this pandemic, you know, on so many counts being one where we can say, yes, it is impacting all of us, still we see these inequities even, you know, within one country or another, but these ways in which we still fail to see that we are not, you know, we are not going to be healthy until we are all healthy in this, that this is truly a global pandemic and a global health challenge, and we need to respond globally. So I really appreciate that call to action in that way, and the important reminder of what our ethics look like in the midst of this as well. Dr. Muchina, as we maybe pivoting a little bit before we move into some action points together in our time, I did want to ask you, you know, as we consider, so, you know, we've talked about a lot of the obstacles that might be present and how to overcome them potentially in terms of production and access to medicines in terms of countries and manufacturing. Are there other obstacles to delivering the vaccines particularly? And when we think about some of the most vulnerable among us, other obstacles that you would like to highlight that we should be thinking of and how we might address them?
Yeah, so when I think of vaccine delivery, especially in African countries, what comes to mind is how weak the health systems are in the continent. Some of the governments are working very hard to improve that. But the reality is there are millions of Africans without access to health services. And some of them, it will take days to access a health facility. When you think of the poor in the communities, you have to start thinking about how you bring those vaccines to them rather than them coming to get the vaccines. So there will be a need to mobilize communities and community workers to take these vaccines to the local communities. There will be need for education because there's a lot of misinformation about vaccines. You know, I have some of my family members saying they are not going to get the vaccines because of the misinformation, especially on social media, but also from some of the faith community people that are saying, don't take these vaccines, they are for family planning, or there's, you know, kinds. And there is, I mean, some historical reason why people think that way. And, so there will be need to debunk those, misinformation and myths so that people can actually accept the vaccines when they become available. But the issue of access to health, how many people have health insurance in the continent, in Kenya today? Very few. Unless the government makes those vaccines free and accessible to everyone, and not free and accessible to the rich in big cities, the people in rural communities will not have access. And I want to revisit the issue that you mentioned, and that is, the role of racism. And in this case, I also want to mention the role of negative ethnicity in our continent, because they go hand in hand. And here in the US, we say, Black Lives Matter. And we've been pushing with President Biden and his administration that Black Lives Matters doesn't only matter, Black lives don't only matter here in the United States, but they matter globally. They matter in Brazil. Majority of the people who are dying in Brazil are people of color. Look at India, look at other, countries in the UK. We lost so many prominent African leaders who are getting treatment in European countries. We lost them, so it begs the question, what role does racism play in accessing healthcare, in accessing the best healthcare you can get? Of course, if you're wealthy, you will have the best, medical treatment that you need. If you're not, and most of people in Kenya are not, you won't. So now it's the role of the government to make sure that people are accessing. So for us as advocates, and for you as people who are teaching students who are going to go out to interact and to serve people in these communities, they also have to learn to be people's advocates, not only, doctors and nurses, but also to advocate so that the government doesn't forget people in rural communities. The government doesn't use negative ethnicity to discriminate against certain communities in the country, and they don't access the health services and the medication, the vaccines that they need. So there is a lot of advocacy that is needed, and there is a lot of challenging of current governments and governments that are coming to be more equitable, and to also cut out corruption, which is undermining the health services in our countries. That is undermining the healthcare systems. When Delta was happening in India, it was so clear that the Kenyan government needed to close its borders and to protect from Delta. What happened, they had a group of investors come from India, and nobody even tested them when they arrived in the country, and they went straight into Kisumu. And suddenly we have an outbreak of Delta in Kisumu. Who are those health officials? Who are those airport officials that let that happen? We have to hold them accountable. We are not discriminating against people, but if you have to contain a pandemic, you have to contain a pandemic. They are talking right now about people not traveling from the Western Kenya because of the COVID in Uganda, but I guarantee you that if you have money and you can bribe police all along the way, you will come to Nairobi from Western Kenya. It was happening even when it was people in Nairobi couldn't go to rural areas. They were doing the same thing. So we are killing ourselves by greed. People are so greedy, but on another level, they are not getting paid enough. So these policemen, they are trying to get more because they're not getting paid enough. The government doesn't pay them enough. They pay themselves big salaries in Congress or in Parliament, but they pay peanuts to police people. So they have to make it by, people bribing their way so that they can, help.
Yeah.
So
and I think, yeah.
Sorry.
Oh, no, it's okay. I was just gonna say, I think you raised such important points about the systems that are at fault here in many ways, and that it does require this action against these systems or to improve and change these systems as well, whether it's the medical system and the systematic racism there, the ways in which the power and political structures operate, just all these layers of systemic challenges, and how we then see the impacts of those most affecting the vulnerable too. I also think your point originally about the need for community health workers reaching people where they are is a really critical one in this as well. Actually, in many ways, something that Kenya did well in the earlier months of the pandemic in 2020 was really pivoting with the use of community health workers to try to, do contact tracing, to set up hand washing stations, really using those public health strategies that were there to try to limit the initial spread, which we some places. I think those are resources, again, that can be supported and built up and should be really well supported when it gets to trying to figure out how to best make available vaccines and the care as well. But I completely agree. We do want to take a moment. So again, thank you to everyone who has joined us. We are going to return to a time where you can ask some questions and some final discussion with Dr. Atwali and Dr. Mushino, but we did not want this to be a time only of listening and thinking. We wanted there to be space for at least one action in this time that you're spending together here. And so we have, I believe, Dr. David is to switch us over, yes, to our advocacy break here. And what we really want is for you to be able to first to connect with organizations who are doing exactly this kind of advocacy work, as is described here. A few of the organizations with which we know are significantly engaged in the work are mentioned here with their websites. We're happy to have additional resources shared in the chat if there are organizations you want to connect with. And I believe we have a link for additional steps as well with this. So again, some of our partners here: Justice is Global, Africans Rising, the Kenya Medical Association, the Right to Health Action. Each of these groups have been trying to collectively raise voices, draw attention to these issues, advocate for policy change, try to equip those who need these resources around it. We would really encourage you to consider a way to support them with your attention, your time, your advocacy, your resources today as well. And then I believe we have one more slide, am I correct with? We also have one of the partners, Justice is Global, has a campaign actively ongoing. Oh, and I think actually we have someone from Justice is Global who maybe wants to speak about this, but you can use your phone to access the QRS scanner there, to go to a link for their campaign that you can sign on to with some really specific actions to take. So I'm going to be quiet for a few minutes. We would really encourage those joining us to go to this campaign, to look at the organizations there as well, to take a few minutes to actually commit to and do or schedule in doing something for action on this topic right now. All right. I hope that everyone at least found an introduction of a step they might be interested in taking, or the chance to connect with some of our many incredible participants in the meeting scheduled today. I did want to ask both Dr. Atwali and Dr. Mushina one more question each, and then I think we'll turn to questions that you might have. So please feel free to type questions in the chat now as well. Dr. Atwali, I wanted to ask you, and I know I did not prepare you for this in advance, so I understand if you need to think for a moment, but I wondered if so thinking about Kenya, if you could take an action at any level in Kenya, essentially imagining that you had a magic wand you could wave and make a change, what would your priorities be for addressing the current vaccine apartheid? Or what changes in Kenya specifically would you correct with your magic wand? Or maybe correct is maybe not even the right word, make possible. What would you bring into being that way?
Thank you very much. The first thing that I would do would be to eliminate the corruption around this pandemic, because there has been a lot of profiteering, even around procurement of essential supplies, procurement of medications, and so on. So I would obviously eliminate that, because that's wasteful and that hampers our ability to go further than we could. So that would be important, and it would free up resources that would then bring me to the second point, and that is that. So if our health system had been properly resourced from the beginning, in fact, one of the things you will notice that countries that had poorly set up health systems or under-resourced health systems suffered more, even though most countries suffered, but those that had poor health systems suffered more. So I would have invested more in the health system in general, in primary health care, in dealing with common conditions. Spending, we committed in Abuja, dozens of years ago, to spend 15% of our budget on health. We are spending probably 6 or 5% if at the last count. So ramping up health expenditure, and in the important areas of primary health care, prevention, ensuring clean supply of water, sanitation, and so on, as well as making available the curative services that are needed to deal with our common causes of morbidity and mortality. That would be a second priority, because if you did that, then you would have sufficient capacity to deal with this severe and moderate to severe illness that is coming, and finding we have no ICU beds, we have no oxygen, and so on and so forth. And the third thing I would do, which might be seen as a little bit more controversial, would be to trash all these agreements that prevent me as a country from manufacturing vaccines that would serve to prevent severe illness in my people. I would indeed trash those agreements, use all means at my disposal to find the technology necessary and the know-how, and empower our local scientists and institutions to manufacture sufficient vaccines to cover all the people that need it in this region. So those are the things that I would be thinking about at this time.
Thank you so much. Thank you. I wish I could give you this magic wand. And Dr. Mushina, I wish I could give you a magic wand as well to take any action that you see fit. For you, let us imagine that you could really take any action or set priorities for next steps for countries, particularly perhaps, let's focus perhaps today, given our audience, on the United States and the EU. What would you set as your top priorities there if you could be the one making the changes?
So a big shout out to Global Justice is Global. Ben is on the call, and Achille is the one who connected me with you. And a big also shout to Africa CDC, because they've done exemplary well by helping African countries, mitigate the COVID pandemic, even though they've been facing a lot of challenges because of political issues, but also because of lack of resources. But one of the things that I would really like to see happen immediately is the release of special drawing rights at the International Monetary Fund, so that low and middle income countries can have access to huge chunk of resources to, produce vaccines, to buy, the necessary medicine and therapies and diagnostic tools that they need, because their resources have already been disseminated by COVID. So the release of special drawing rights at IMF is so critical, and they need to do it immediately. I don't know what they are waiting for. They say that they were going to release at least 650 billion, which we are still waiting for them to do. Now they are promising to do in August, but that's not going to meet the demand, but at least it is a good start. Then we want to see them release at least 2 trillion US dollars so that these countries are empowered to be able to save their people. You see, when it was the US that was in an economic crisis in 2008, they acted so quickly. They didn't even think twice to do it. And these are resources that it's not alone, and it is due to every country that is a member of the International Monetary Fund. So they can release it even today or tomorrow, and it can go and save lives, and they're still holding on to it. And the big holdups, again, it's European Union. So I'm asking Angela Merkel as a woman, you know, she's letting us down as a woman, because I have supported her leadership together with other women globally. And we thought that as a woman leader, she would have more compassion, more mercy to save women. And women are crying to her globally that she needs to stop that shenanigan and save lives. You know, so she needs to support the TRIPS waiver at the WTO, and they should do it now. July is the cutoff month. They shouldn't delay until December. So my magic wand, vaccines for everybody. My magic wand, resources for everybody, so that we can mitigate the pandemic. There's no way we are going to mitigate the pandemic without those two things going hand in hand. And the third one, stop neocolonialism. Because I think, you know, neocolonialism attitudes and approaches are the ones that have put us where we are. The policies that they've made are actually made from a colonial mindset. So when you try to apply them to African countries, they don't work, because they are not designed to help us. They are designed to continue oppressing us and preventing us, you know, from moving forward. And I want to remind the whole world that we are a global community. My safety is your safety. We share a common humanity. We share a common world. We have a shared security. So what the resources we have need to be shared, remembering that by saving me, you are saving yourself at the same time. Thank you.
Thank you so much. I wish we could give you this magic wand, as well as all of the appropriate positions and power that would be needed to make it happen. And I appreciate how you've used your magic wand for the really big and important things that would truly cause corrections here. There is a question from the chat for you, Dr. Mushina, about how diaspora communities, perhaps especially in the United States, might support the movement for global vaccine equity. I appreciate that some members of the chat have also offered some suggestions, but I wondered if you had any suggestions you would like to particularly speak to diaspora communities right now.
So the first and foremost is to join the movement. There is a movement going on here in the United States. You can join Justice is Global. You can join Advocacy Network for Africa. You can join Oxfam. You can join the People's Vaccines. You can join the Special Drawing Rights Coalition. So there are so many movements that people can join. And if you email me, I'll be happy to connect you. I put my email in the chat so you can see it. And also, I'm sure that the organizers of this conference also have those emails and links, and they can put you in touch. The other thing is, don't forget to send resources back home. You know, I know that we had to fundraise for Zimbabwe. I'm not from Zimbabwe, but we work in Zimbabwe, but to buy PPEs to make sure that the people there had the medical staff had PPEs to be able to see their patients. We fundraise for Somalia as well. We have very huge populations of African people from Africa who are here, and people of African descent. So when we have these movements, let's remember that we came here, you know, by grace. And we are not here only for ourselves. We are here, yes, to better ourselves, but remember what you left behind. So send resources back, yeah, either through some of the coalitions that are there, or you can send resources directly to family. But if you really want to make a change in policy, join us in advocating with the policymakers here and European Union at the UN as well. Africa Union, we also have an office at Africa Union where we are pushing them as well. We have an office in Kenya. So American Friends Services Committee has an office in Kenya as well, where we are really trying to change policies at all levels. So don't sit at home and that, you know, there's nothing to do. There's so much to do. And if you can't get out at this point, you can send an email, you can make a phone call, you can send a letter, and definitely donate, you know, to make a difference. Thank you.
Thank you. That is a great call for action for us to conclude our time together. Thank you to everyone who has joined, and thank you especially Dr. Mushina and Dr. Atwali for your insight, your words, your calls to action today. It is really appreciated, and I hope that we can continue to highlight your voices with this. Please note, we do have an evaluation link that was put in the chat for this session. We would love to hear feedback on what we might do to improve or your thoughts about this. Please consider joining us again in a few weeks for our next session that will be focused with a spotlight on Colombia. We look forward to similarly highlighting and talking about relevant issues, and again, coming together for action around global vaccine apartheid. Again, thank you to Dr. Atwali and Dr. Mushina, and thank you for everyone for your time today. Take care.
Thank you very much. Bye-bye.
Thank you.